Next is
Dr. Meer Chisthi, sir. Associate Professor, Department of General Surgery, Government Medical College, Konni, Patnamthitta. We are running short by 45 minutes. This is just for the information of the chairpersons. Thank you.
Respected chairpersons, distinguished colleagues, good afternoon to one and all. Let me start off with a word of gratitude to the organizers for having given the chance to discuss this very important practical topic, how to prevent and treat post-mastectomy lymphedema. Let me start by relating the story of my friend. She's a practicing doctor, now into her late 30s. A few months back, she detected by herself a lump in her left breast. And with a strong family history of breast cancer and all the workup turning out to be positive for malignancy, the decision was taken for a mastectomy. She had no problem with that. But as you and I would do, she went to Google and she Googled for post-mastectomy complications. This is one of the complications which came up on top. She then called me, she's my friend. Is this common? Can something be done about it? So let's see. Lymphedema, by definition, is the accumulation of fluid which is rich in protein in the interstitium with superadded inflammation, subsequently leading on to fibrosis. What does this lymphatic system do in our body? Basically, it acts as a surveillance system, taking away all the debris, the unwanted viruses, the bacteria, the proteins, including even cancer cells. These are carried away onto the lymph nodes where they are cleansed and the purified lymph is given back to the circulation. It also aids in metabolism of fat. All this is done through this system called as the lymphatic vessels. The basic unit is what is called as a lymphangion, which has got valves of its own, which helps to push the lymph forward. This action is what is called as lymphangiomotoricity. So basically the lymph transports about 2 liters of fluid from the interstitium back to the circulation. So what are the risk factors for a post-mastectomy lymphedema? Evidence says it is almost 4 times higher in patients who undergo a proper axillary lymph node dissection as compared to a sentinel lymph node biopsy. And the other risk factors being increasing weight, a higher duration of neoadjuvant chemotherapy, and more number of lymph nodes involved by tumor or more number of lymph nodes removed during an axillary dissection. It starts anytime after surgery, but it is classically seen within 3 years after the mastectomy. There is a slow but steady worsening, and even trivial things like a bite by some insect, or bee sting, sunburns, or sometimes even carrying a heavy baggage on your shoulder, all these can trigger an episode of lymphedema. There is accumulation of protein, accumulation of fluid with subsequent decrease to the oxygenation of the tissues. All this leads to a slowing of the tissue healing time and accumulation of fat as well as fibrosis. So how do these patients present to you? They do not complain of pain. Rather, they would say they have a feeling of heaviness, the limb being congested. Mind you, if they complain of severe pain, you have to rule out other problems, including a radiation-induced or malignancy-induced plexopathy. You can demonstrate the classical Stemmer's test where you will not be able to pinch the skin. And how do you document this? The simple thing is, when the patient comes to you for review, take serial photographs so that you can know when there is a significant change in the size or the girth of the limb. The girth measurements are taken at 10 centimeter intervals across the limbs. The body weight needs to be monitored, and there are multiple methods for volumetric assessment, including water displacement, 3D laser, bioimpedance spectroscopy, and each has got its own set of advantages. Any difference of 2 centimeter in the circumference between the affected and the normal limb, or any difference of more than 200 milliliter volume between the affected limb and the normal limb is to be considered significant. Of late, ultrasound elastography is gaining reputation as specifically useful for lymphedema. There are many staging techniques available, including the Cheng's grading, the Emomato, decampasy, but the most commonly followed one is this, the International Society of Lymphology. You have basically 4 stages. Stage 1 is asymptomatic or subclinical. Sorry, stage 0 is subclinical. Stage 1 is reversible and pitting edema. Stage 2 is again divided into 2A, 2B. Stage 2A is pitting edema, but it is usually irreversible, whereas stage 2B is non-pitting. And stage 3 is the classical, the florid elephantiasis with all the fibrosis, the thickening, the warty growths. So you can see the classical stage 3 with all the evidence of filariasis. Imaging techniques, mostly you can do either a radionuclide scintigraphy or indocyanine green lymphography or even a magnetic resonance lymphography. Of the 3, the most commonly followed one is ICG because it doesn't have the side effects of radiation. It can be done as an outpatient procedure. So you have done your mastectomy. Can you do something to prevent it? The most important thing is to stimulate the patient to be active from day 0 onwards. On the day of surgery itself, advise the patient to practice deep breathing, do relaxation. On the bed itself, they can do simple exercises including the shoulder rotation, the chin tucks, etc. And as soon as they are active, go for more active exercises, including these are called as the cane stretching or cane walking. They can be advised to do the wall walking. All this doesn't take much of effort, but they do benefit the patient in reducing the incidence of lymphedema. And as again confidence, advise them to do positions like this, the praying child pose, or they can simply pull over the pulleys. Risk reduction strategies include proper care for the skin, avoiding temperature problems, an active lifestyle, avoiding constriction to the limb. Skin care, you have to keep the limb moist at all times. Nail care has to be done, but you should never cut into the cuticle. The skin has to be protected from all harsh things, including insects or harsh sun, and all injections and blood test, even a simple BP measurement has to be preferably taken on the unaffected limb. Extremes of temperature, both hot and cold, are to be avoided. And the patient has to avoid putting constricting garments, especially those with an elastic cuff, even a BP cuff or tight-fitting jewelry. All this has to be avoided. Because most patients happen to be ladies, you can specifically advise them not to carry handbag, especially if it is heavy, not to carry handbag on the affected limb. Compression garments are especially useful if they are doing active exercises. During the activity, they can put these compression garments which can reduce the incidence of occurrence of the lymphedema. Activity is very, very important, but one thing is to be noted, this has to be monitored. They have to take sufficient rest in between the activity. Whenever possible, the affected arm has to be kept in an elevated position. So in spite of all this, the patient has already developed lymphedema. What do? The treatment, the accepted protocol is what is called as a complete decongestive therapy. It includes short stretch bandaging, lymphatic massage, not casual massage, but a protocol-wise supervised massage, proper exercising, meticulous care to the skin, as well as patient education. It has two parts. The first part is the phase of decongestion, which is a supervised regime where you do exercise, give proper care to the skin, and teach the patient regarding how to do a manual lymphatic massage and compression bandaging. The phase 2, which is the maintenance phase, is more of a self-directed approach where the patient does all this at home with frequent visits. Regarding this massage, what you need to know is that this is not a casual massage. This has to be given or administered by practitioners who are trained in this. This starts from the central trunk, then the proximal part of the limbs, and later to the distal part of the limbs. The pressure should be optimal so that the lymphatic vessels are stimulated and not compressed. It's a rhythmic movement like this so that the lymph is promoted to drain more easier. Following this, you can apply the compression bandage. Evidence says CDT is very effective in reducing post-mastectomy lymphedema. But it has got its own set of contraindications, including deep vein thrombosis, cellulitis, peripheral occlusive arterial disease of moderate variety, and even sensory or motor paralysis. Can you do surgical options? The previous textbooks used to say all the limb reduction procedures, Sistrunk, the Charles, the Homan, then the Thompsons. Nowadays, these are mostly abandoned and kept for moribund cases only. Instead, what is practiced is liposuction. And now the golden boy in the realm is nothing but lymphatico-venous anastomosis, where you identify the lymphatics with the help of indocyanine green, and these are anastomosed in an end-to-side or end-to-end or a side-to-side fashion to the lymphatics. So the lymphatics are anastomosed to the veins, so that helps in drainage. And the protocol has been given the name as LYMPHA, lymphatic microsurgical preventive healing approach. This is gaining importance in this treatment. But this is effective only in early stages because the vessel becomes sclerotic as the stage progresses. The other option is a vascularized lymph node transfer, where you take lymphatic tissue with its blood supply and put onto the recipient site. The problem being donor site edema, which can be prevented by reverse lymphatic mapping and avoiding the sentinel lymph nodes. This is nothing but VLNT. Now momentum is gaining importance in this. Then there are some other techniques which are not much proven by the literature evidence, but they have some anecdotal evidence too. So just to summarize, early stages, a CDT is good enough. In intermediate stages, CDT combined with lymphovascular anastomosis and vascularized lymph node transfer. Later stages, nothing works. You have to go for debulking along with liposuction. And regarding my friend, I am happy to say that she underwent mastectomy along with immediate lymphatic reconstruction at one of the major institutions in Trivandrum. Now she's doing well. She has gone back to her clinical practice. Thank you.
Thank you, Dr. Meer. We are running short of time. But whether any medicines can be tried other than your surgical procedures, and you already mentioned.
Yes, sir.
What about some coumarin group of drugs?
Yes, sir. Like as per the evidence, there are many drugs which have been tried, but as per the meta-analysis, none of them have been proven to be effective. Ketoprofen has limited role, but there is no strong evidence to recommend any of the pharmacological agents.
What we have found is that in one of the cases, is the infection. Those cases, mastectomy, where they develop postoperative infections, prone to develop these lymphedema.
Yes, sir.
The incidence is
Yes,
found
sir,
to be
right, sir.
more.
Yes, sir. Rightly.
And also, I don't know, there's the incidence of sarcoma. Why, can you
Thank
just
you.
mention why it is more in lymphedema? Stewart-Reeves syndrome?
Yes, sir. Stewart-Reeves syndrome.
Why?
Beg your pardon, sir. We'll have to move on. Thank you.
Thank you.
Okay.